Next, we'll see about HPV and cervical cancer. So HPV is called as human papilloma virus, and it is going to be a oncogenic DNA virus. So we have various strains of this HPV virus. Out of this, we are going to classify it into high risk type and low risk type based on the strains. So the very most common high risk strains will be HPV 16 and 18, out of which 16 is responsible for more than 60% of the carcinomas. So HPV 16 is the most important high risk strain. Other than that, you can also have HPV 31, 33, 35, 39, 45, 51 and 52. These are all again high risk HPVs. Then in low risk HPV, we have HPV 6 and 11. Then you also have 40, 42, 43, 44, 54 and 55. Okay. So these HPV, high risk HPVs are associated with variety of squamous cell carcinomas. So where all can it cause this squamous cell carcinomas? It is going to be most commonly related with the cervical carcinoma. So in cervical carcinoma, both the squamous cell carcinoma and adenocarcinoma is going to be related with the HPV. Okay. So nearly more than 90% of the carcinomas in cervix are associated with HPV. And then you can also have vulval cancers, anal cancers, penile cancer. So basically anogenital cancers, then laryngeal cancer and oropharyngeal cancer. So in the oropharyngeal cancer, it usually occurs in the tonsil. So tonsillar region, you get this HPV associated cancers. Then in esophagus also, some cases they are having an endemic predilection to HPV, and in those patients, it can develop into a esophageal cancer also. So all of these cancers are associated with high risk HPV. While low risk HPV like HPV 6 and 11, they usually form warts. So warty lesions called as condyloma acuminata. So you will see it in the genital regions again. So condyloma acuminata, these are warty lesions caused by low risk HPV, which are 6 and 11. So how does this HPV cause cancer? Normally, it is going to be acquired as a transient infection in any of the sexually active females. So usually around 20 to 25 years of age group, most of the females must have acquired the infection as such. So it usually occurs as it is transmitted through sexual intercourse. So sexually transmitted, and also it is also going to be transmitted through skin and mucosal surface contact. Okay. So when all of these females are actually exposed to this HPV infection, why are not everyone developing cancer? Because with the immunity, the patient's immunity is going to be developed against this infection, and this infection will be cleared off within some time. But when the patient's immunity falls down, or there is some other environmental factors or some other risk factors associated with it, like a co-risk factor like HIV. So co-infection with HIV, or some other mucosal abrasions or breaks, or immunocompromised status. So all of these conditions is going to trigger the HPV infection to transform into a intraepithelial lesion, which then again progress onto a cancer. So HPV is associated with both precursor lesions and then cancers as well. So it is important to diagnose this precursor lesion so that we can prevent its development into cancer. That is why screening programs have been introduced to diagnose the patients before they develop this precursor state also. Okay. So it usually takes at least a decade time. So 10 to 15 years time it takes for an intraepithelial lesion to develop into a cancer. So the patients need to be under follow-up. So what actually happens is that this HPV infection is going to attack the basal cells of the squamous lining. So this is the stratified squamous epithelium, and this is the basal layer. So HPV infection is going to attack the basal cells. So as the basal cells mature and reach the topmost layer, this HPV virions will also be coming into this squamous lining. So as they enter this above layers, it is going to acquire some mutations. So that is when it is going to lead into a cancer. So what happens actually is this HPV has two protons, which is E6 and E7 protons. So this E6 proton is going to degrade P53 proton. So P53 is the guardian. So without the guardian, P53, everything is going to change here. The cell cycle will progress without any check. So E6 proton will attack the P53, while E7 proton is going to dysregulate the retinoblastoma gene. So P53 and RB genes are the major cell cycle regulators. So when these these checkpoints are being deregulated, what will happen? There will be uncontrolled cell cycle proliferation. So cell cycle is going to progress uncontrollably, and that will progress on to cancer. So this E6 and E7 proteins are going to be elaborated mainly by the high risk HPV. So the initial lesion which this high risk HPV causes will be a low grade squamous intraepithelial lesion. So in the cervix we call it as LSIL, which is low grade squamous intraepithelial lesion. And here the classical appearance will be the formation of coilocytes. So coilocytic change is the viral cytopathic effect related with HPV. So in coilocytes, you are going to have a central nucleus which is going to have irregular nuclear membrane. It is going to be shrunken and appearing like a raisin. So this nucleus is called as a raisinoid nucleus, surrounding which you are going to have a perinuclear halo. So if this is the cell, this is the halo, and this is the raisinoid nucleus. Okay. So this cytopathic effect is called as coilocyte, and it is associated with HPV infection. So when you see a coilocytic change, then you will have to call it as a LSIL lesion. Suppose there is a high grade lesion. So in HSIL lesion, there is going to be dysplasia in this squamous epithelium. So in LSIL lesion, you can either see a coilocytic lesion or dysplasia, which is limited to the lower 1/3 of the epithelium. But as the squamous cell matures, it is going to develop into HSIL lesion, wherein HPV virions are again loaded with it. So in HSIL lesion, there is going to be dysplasia, which is going to affect the lower 2/3 of the epithelium or the entire epithelium itself. So the full thickness epithelium is going to be affected. So this we call it as SIN 2 or 3 in the cervix. So SIN 2 is till lower 2/3 of the epithelium, while SIN 3 is full thickness epithelium. Coilocyte, and you will have lower 1/3 dysplasia in LSIL. So these things you need to remember. This was the question which was asked in the previous year NEET. So how do you test for this HPV? How do you prevent this infection? Either it is mandatory to now to take the HPV vaccines. So HPV vaccine the females can take, and other than that you will have to undergo a screening. So post 21 years of age, females are directed for a screening test which is called as Pap smear. So screening for cervical cancer is done through this Pap smear, which was developed by Papanicolaou. So from 21 to 29 years of age, it is recommended to take a Pap smear testing. So along with that, you can, if there is going to be some kind of abnormality in the Pap smear, then they'll refer for a reflex HPV DNA testing. So you can measure the HPV DNA also using various molecular methods like PCR under the following tests. So you can either do a Roche-Cobas test, a hybrid capture test, or a Cervista test, or an Aptima test. So if you do a Roche-Cobas test, the FDA had approved more than 25 years of age, you can do a single, you can do only HPV testing. No need of co-testing with Pap smear. So FDA had approved in this Roche-Cobas test, for which more than 25 years of age group, the females can undergo a HPV testing alone. Okay. So when you are doing a Pap smear, so 21 to 29 years of age group, you are going to do a Pap smear, and if there is any abnormality, then you have to do a reflex HPV DNA testing by any of these methods, and that is going to be repeated every 3 years. Then 30 to 65 years of age group, you can either choose to do PAP every 3 years, or you can do PAP plus HPV testing every 5 years. Okay. Then if it is more than 65 years, you can stop screening only if there was no abnormality detected when any of the previous testing. So all these years you had tested, you had undergone screening, and then you don't have any abnormality or any risk factors, then post 65 years of age, there is a screening is not recommended. So on Pap smear, we are going to use a Bethesda system for reporting the abnormality. So you have various classifications of squamous abnormality, then glandular abnormalities. So both squamous cell carcinoma and adenocarcinoma can be detected in the cervix. So Bethesda system Pap smear screening is going to be for cervical cancer. So let's see some image-based questions related to it. So for Pap smear, you are going to use a IR spatula. So this is the IR spatula you must have seen in the gynae OPD. So this kind of biforked spatula will be there. So this biforked end is the one in which which is the one which is entering into the cervix. So they just rotate it, and then they'll apply whatever material was there on a glass slide and make a smear out of it. Then you will have to immediately fix the smear with 95% ethanol. So 95% ethanol is going to be the fixative for Papanicolaou stain. Okay, so this also is a question. So 95% ethanol, you have to immediately fix the smear so that drying artifacts are avoided. Okay, so after you fix the smear, then you have to stain it with the Papanicolaou stain. So PAP stain is going to give better definition of the nuclear details. So here we are actually concerned with the nuclear details, right? So more than the cytoplasm, we need the nuclear details for classifying in the Bethesda system of reporting. So for nuclear details to be clear, we need to use the PAP stain. So under the normal PAP stain, you will see the squamous cells like this. So these cells which are pink in color, right? So pink in color and a central dot-like nucleus. So this is going to be the mature squamous cell, the most mature keratinized squamous cell. Okay. So keratin will appear pink in PAP smear. So that is why it is appearing pink here. So these blue cells are also squamous cells only. Here again the nucleus is kind of small. So these are intermediate squamous cells. So intermediate squamous cells will appear blue in color and again the nucleus is going to be small. And these cells, the third image is going to be parabasal cells. Parabasal or basal cells, they will appear kind of dark and smaller than the mature squamous cell, and their nucleus will also be quite bigger than that of a mature squamous cell. So the last image is that of the endocervical cells. So endocervical cells are actually columnar cells which have mucin. So if you appreciate here, all of these cells are having the nucleus at the base. So they have the nucleus here at the base and this is all appearing empty. So this is all appearing empty, right? So this is all the mucin. So all of these cells are the endocervical cells. So when you see any nuclear abnormality in each of these cells, you will have to report it as an abnormality under PAP smear. So the first image here will be here if you see, this is a mature squamous cell, keratinized squamous cell. This is a intermediate squamous cell which is normal again. But in this cell, if you appreciate, you are having some halo kind of thing. So it is a clear space around the nucleus. So this is the nucleus and this nucleus is, how does the nucleus appear like? It is not round and regular like this. It is enlarged and it is all having an irregular nuclear membrane and even the chromatin is kind of having a clumped chromatin. So this kind of a nucleus is called as a racinoid nucleus which is surrounded by this perinuclear halo. So this cell is going to be called as a koilocyte. So koilocyte was the cytopathic effect associated with HPV. So this lesion is going to be called as an L-cell lesion. Okay. So the corresponding histopath image of this L-cell lesion is on the right side here. So this is the basement membrane of the squamous lining. So here again if you see, there is some kind of polarity loss in the basal 1/3. So lower 1/3 of the epithelium, there is going to be dysplasia. And apart from that, you are also able to see these kind of koilocytic cells. So here again, you are having these perinuclear halo with a racinoid nucleus. So here koilocytes are also present. So this is an L-cell lesion again. Then you will see about H-cell lesion. So on cytology PAP smears, if you see, these are cells which have, most of the cells are having a very bad looking hyperchromatic and a irregular nuclear membrane. And the cells are also quite small as compared to this cell. This cell is quite small, but the nucleus is quite enlarged as if it is appearing to occupy the entire squamous cell. So these are going to be affecting the parabasal cells. In the parabasal cells, if you are having these kind of high NC ratio hyperchromatic nucleus, then it is going to be called as H-cell on PAP smear. And here on histopath also, you can see this is the basement membrane. So there is no invasion as such, but here if you are seeing, the entire epithelium is having dysplasia. So the polarity of the cells is all altered. The cells are all having enlarged nucleus, hyperchromatic, and the polarity is quite altered. So this kind of full thickness dysplasia is going to be called as SYN3. Or if there is atypia up till here, that is only the lower 2/3 is being affected, then again it is going to be called as SYN2. So both SYN2, which is cervical intraepithelial neoplasia, so both SYN2 and SYN3 are considered as H-cell lesions. Okay. So the question was actually, what is seen for a H-cell lesion, I think. So answer was dysplasia. So in the options they had given metaplasia, dysplasia and other things. So the answer was dysplasia in that.